Okay, so in this next session, I'm going to shift gears and spend just a few minutes, hopefully it shouldn't be more than half an hour, talking a little bit about what we've seen and setting the context as far as motivations for system science approaches. And my thought here is that based on the pre-survey, for which I'm grateful for so much participation from you folks, I saw a fair bit of indication that many people here have had some conceptual exposure to system science and motivations for it, to what are sometimes called complex systems methods, dynamic modeling, simulation modeling, either as a whole or in one of its particular traditions. I'd like, though, to sort of try to frame some of the issues there, both for those who have not had that previous exposure, of which there are some, and secondly, to make sure that you capture some of the formative ideas, but behind the types of modeling we'll be talking about in the course of the week, in as much as they may differ from what you've heard before. So I'm going to be going very light over these materials, and I'm going to have to ask your pardon up front for skipping quite quickly over some slides. So this is the brief motivation for system science methods approaches. From my perspective, much of the motivation lies in the fact that increasingly we are confronting ever more complex health challenges worldwide. Whether you're in North America or Australia or Africa or Europe, Asia, increasingly we struggle with a world that's ever smaller, where population travel patterns can bring communicable illnesses from one place to another, where globalization adverse impacts on ecosystems and so on is exposing individuals to complaints and to disease burdens which were unthinkable even 50 years ago. Increasingly we see zoonoses, emerging infectious diseases which pass the human-animal barrier and emerge from areas that were sparsely inhabited previously, have been opened up to development, and now are increasingly finding their way into human populations, whether it's MERS or SARS or aspects associated with even H1N1 or H3N2 or aspects of HIV. We're increasingly in a small world where we're connected with a host of other people worldwide and with various animal species and evolving relationships. We're also dealing in many areas of the world with an aging population, demographic shifts, which impose very stiff cost and service delivery implications for our healthcare systems. And also in a world where many of the burdens in condition after condition fall on the same communities. We see in northern Canada, for example, in a quite terrifying way, very real aspects of syndemics, cases of mutually interacting conditions that have been documented so well by Singer and other colleagues, linking up sometimes different health issues, TB and diabetes, for example, in a way that's quite adverse, but also with behavioral and social science components that are very pronounced, such as substance abuse, violence, addictions, and interactions between homelessness and aspects of poor social support with conditions like HIV and hepatitis C. We're also increasingly aware of the impacts health disparities are imposing on the population, the presence of critical periods in the life course, and the lifelong shadows cast by early life insults on the life course. Our work of Barker since 50 years ago has shed light on the fact that there's very pronounced health disparities across the life course borne by individuals that reflect their early socioeconomic status when they were born and as young children. And we know ever more clearly that whether because of epigenetics, whether because of critical periods in people's lives, there are big exposures to chronic diseases seen later in life that are associated with those early exposures and early encounters in childhood trauma. And we're also trying to counter ever more nimble corporate actors. I do a lot of our work these days, as I did 15 years ago in the tobacco side, trying to finish this issue off that has had so much progress but is stubbornly resistant. And so much of what we do there is trying to outmaneuver tobacco corporations and so on, who are extremely agile in taking advantages of new media, taking advantages of messaging that takes that is aimed at young people, using the most advanced technologies in ways that it's running circles around the public health system. So we're dealing with very complex health challenges, with an interconnected, entangled world. And traditional techniques have secured us tremendous insight to build on. I include here RCTs, pathway-specific lab studies, large-scale epidemiological studies, statistical analyses regarding associations of risk factors and focused outcomes. And these techniques have lent a great deal of understanding of the pieces of those particular pathways, of particular associations. But this reductionist strategy, while it's extremely valuable for filling in some details, there's limits to what it can accomplish. There's limits in the same ways that having someone who's extremely skilled in all the pieces of a car can be very, very valuable for certain types of tasks to have your car repaired. But it offers limited insight if we're trying to think about how to prevent traffic jams. We think about traffic jams, they're not fundamentally just about car engines, they're not fundamentally just about car mobility, they're not fundamentally just about the shape, the curvature of a road or its number of lanes, they're not just about the road network, they're not just about driver perception and driver styles in different regions. They are instead about the entanglement of all of these. So we can know a tremendous amount about cars and roads and so on, but still a very limited understanding of how to prevent traffic jams. Similarly, so it is with a lot of health issues. We can have extremely detailed knowledge of the human genome, but have limited understanding of how that ripples through to high burden conditions and what to do best about them. Reductionist approaches have tremendous benefits that they can offer in terms of insight, but there's another piece that's needed to complement them, a piece that goes from those several separate, fragmented elements to an understanding of how they relate to the whole, to those emergent patterns that we see bedeviling our communities and nations in terms of health burdens. So going from this micro scale to the mesoscale to the macro scale is not a matter of the pieces. It's a matter of putting those pieces together. We need a science, ladies and gentlemen, of the whole. And this is not merely an academic exercise. It's not merely because it's amusing or of interest, but because it matters to figure out how to lower these health burdens that are so troubling in many areas of our countries. And so, whether it's aspects of these syndemics or aspects of sort of the health ecosystems associated with multifactorial conditions such as obesity and associated with tobacco use, whether it's dealing with emerging infectious diseases and disequilibria phenomena associated with adverse health conditions, or reasoning about implementation science, we need something that's about more than the pieces. I've done a lot of my work in the area of obesity and diabetes, and particularly the area related to Aboriginal health. And we know that the narratives are very tangled. They don't, they're not amenable to simply a neat biomedical description. We have, complex interactions between factors at the physiologic level, at the level of the built environment and the food environment, and at levels associated with the city planning and the shaping of streets, availability of recreational spaces, but also of diverse actors, food retailers, the agricultural producers. We have interactions with agricultural policy at the national level that ripple through and influence our food environments. And we know that there's interactions with other conditions and other health burdens that are profound and lie under the surface. And in this case, as well as many others, we see a situation where the whole is greater than the sum of the parts, not in the sense of better than the sum of the parts, but in the sense of it's different from the sum of the parts. And the observation here has been, and there's been elements that's realized for centuries, that the interaction of very simple components can sometimes yield overall patterns, emergent patterns, that are very different from what we see of those individual pieces, that are distinctive. The patterns of a traffic jam as being very distinct from what you see with any one particular vehicle. And, these often relate to those pieces in ways that are not fully clear and that need to be explicated if we want to be able to improve the situation. If we want to be able to improve and lower the health burdens, we need to be able to reason about how those health burdens reflect are coupled with particular aspects of individual health behavior and of individual environmental interaction, or else we may find ourselves running afoul, working at cross purposes with the nature of things. Now, there's two big needs that confront us in the space. One is the need to explain what's going on. What's happening here? My colleague Ross Hammond speaks about different uses of models and would map this to kind of to uses of models that are in a way, not in a critical way, but backwards looking, ways that are retrospective. What's going on right now out there? Does the evidence that I have available to me support my hypothesis about what's been going on? What's been driving these patterns that we see in the population? What's driving the fact that we have both chronic and communicable diseases at such high levels in many of the same communities in Canada's north? Is what I'm seeing in terms of higher levels of reporting associated with a notifiable disease, is it a good thing or is it a bad thing? It could be a very bad thing in the sense that it's reflecting higher levels of incidence. It could be a good thing in the sense that we're catching more cases out there. What's really driving this? Is this good or bad? Where is it likely to go next? Where is this heading? And we've known for centuries, this is a graph from the 1700s showing deaths from bubonic plague, that there are these patterns epidemiologically that we see in reported data that are just profoundly different from what we know of the natural history of that disease at the individual level. We see these patterns, for example, before vaccination for many childhood infectious diseases. We do a lot of work these days with pertussis, for example, and soon measles, and some work as well with chickenpox that you may be hearing about in the context of this week. And these patterns long interested epidemiologists because they were hard to explain using just the medical knowledge of the time. We also know that many individuals within families and in some cases outside of families, between a patient and a doctor, for example, are coupled in complex ways. For example, linkages between child well-being and caregiver well-being. You can't study one without having implications for the other and needing to bring the other into the frame of focus. And we've known since for years, including the controversial work of Christakis and Fowler, that there's some interactions going on at the level of even of chronic diseases and its risk factors involved in networks. There's multiple interpretations from this. My colleague Ross Hammond has shown that this work by itself, has multiple interpretations in terms of selection of friends, in terms of influence of friends, as to what might be driving it. But we know it does present a significant pattern showing associations at a network level between obesity of immediate connections, of reported close contacts, and of oneself. And we know there's important aspects of spatial patterning associated with health disparities, for example, that cross one condition over to another. And we know that many of these conditions, particularly it's been long recognized in the communicable disease front, but increasingly on the side of health behavior that serve as risk factors for chronic conditions, there's important network effects. These patterns that we've just seen are very structured, but they're very different from what we see for any one piece of the pattern. And really they reflect emergent properties of a system. And as I said, anticipating this emergence, understanding where it's coming from, why you see it, and how it would be different in various counterfactuals is really important for formulating robust and cost-effective interventions. So making sense of the system, what's going on, has implications for interventions as well. And this is the other big need. The need that Ross talks about as prospective need, sort of think about what ways could we bend the curve going forward through interventions. Where to best intervene? How soon will I expect to see an effect? How can I scale up from the micro level to the macro level? To what degree can I take that intervention that worked really well in Melbourne and translate it to Dubbo? Are we able to build these interventions in ways that are financially sustainable? You could have an ecosystem of interventions, some with the tax revenues from taxes on sugar-sweetened beverages supporting, enhanced recreational spaces or what have you. And where to best intervene, on whom, in what conditions, in what ways. We know that, for example, bridging individuals in the communicable disease front are of particular interest because they can serve as the conduits from pathogen making its way from one community to another, but they also exist in terms of spread of knowledge, attitudes, and beliefs. And we know that that within many of these contexts, it's not just the average person, whatever that means, that makes the difference. It's not just the behavior of the sort of the mean situation in the population. Certain subpopulations can have incredibly influential impact on the spread of a disease, of a pathogen, or in the spread of norms, attitudes, and beliefs. And since the 80s, since the work of Heathcote and York, we've recognized the key role that network cores play in even keeping an infection alive when the epidemiological data should suggest it should die out of the population as a whole. And we know there's great variety of behavior within across different people, where small subset of members of a population can be, as it were, the tail that wags the dog. It's there where the action's at. It's not the other 95% of the population. It's that small subgroup which is where the attention has to be focused and where the game will be won or lost. We also recognize early on from the communicable disease context, from work of Kermick and McKendrick in the late 20s, I believe, first recognized this possibility, that there are real tipping points associated with health burdens. Tipping points where if you can just make enough investment, just a little bit more can make that difference, tip the balance, and change the situation qualitatively from one situation to another. We see this, of course, most notably in terms of herd immunity, which is now being jeopardized by falling vaccination rates in many areas, many jurisdictions. But It's also a feature of many complex systems, including ones that are posited to underlie the spread of risk factors for chronic disease. And we know within that context, in these contexts of complex systems in general, the key role that feedbacks play. And I spoke earlier about the effects of early life insults on life prospects and the possibility of ripple through effects to subsequent generations, but also the fact that we know in our societies wealth breeds wealth. Adversity breeds often adversity. Feedbacks are a central driving feature of systems, and we need to learn how to anticipate them and fly ahead of the plane instead of working at cross purposes with the nature of things. So system science here recognizes that a lot of what we've seen in those graphs I had of various patterns of network structure, etc., these patterns are not merely isolated observations concerning the world. They are interlinked by the fact that they're reflections of underlying processes. They're reflections of underlying data-generating processes, as it were, that are causally tangled, that are interacting with each other in complex ways, that exhibit delays, feedbacks, nonlinearities, profound effects of heterogeneity, etc. And to really understand why these patterns persist, these patterns of syndemics, for example, within our communities, and why they resist efforts to correct them, and how we can most effectively ameliorate them, how we can most effectively reduce these health burdens, we need to at least reason consistently about the processes giving rise to them. If we don't, we risk working at cross purposes to the nature of things, of banging our heads against the wall, as it were, of being, as Jeff has long commented, like King Canute, who was assured by his advisors that anything was possible within his realm. He had full power, and he demonstrated to them that he could rail against the rise of the tide. He could order it back, but he was not able to command it. And so it is with our public health systems. We sometimes aspire to greatness, but run afoul against the nature of things. System science plays a role here as this, what I like to term the science of the whole. It's about taking that understanding, the pieces, and putting it together to understand what it means for the system as an entirety. To understand how effects in one area of the system ripple through to affect broader system behavior in other areas of the system. And system science can help us visualize, understand, and reason about the implications of understanding regarding what's going out there, and to test their consistency with evidence. This is not about putting our faith in some particular model, some particular understanding. This is about debugging our thinking about what's going on more quickly. It's about finding mistakes in logical inconsistencies we wouldn't have realized unless we put it down explicitly and unambiguously on a computer and saw the natural consequences as only a computer can compute. And a central way in which system science achieves these goals is through the use of these constructs we call dynamic models. It's not the only way. There's other aspects of system science, complexity science, that are also of potential interest. But a central way is through dynamic models. And these models weave together representation of our hypotheses concerning factors in the world, what we posit might be going on out there, and empirical evidence. And by representing sort of how things might work, these models can help service these thinking tools and help us share our assumptions with others, help us collectively refine our understanding, take it out of our head, putting it in a shared place where we can look at it, critique it, refine it jointly, and more quickly discover inconsistencies about it. So, I've spoken about features of the system that point us to system science. Presence of feedback, path dependence, where an early adverse event, for example, sets our life trajectory off in a way that 60 years later can still be playing out. Where there are complex effects associated with interaction between different actors, where there's different phenomena viewed at different scales, and effects of very localized impact on situated agents. And particular individuals, they're shaped by their particular environment. They make decisions and take the consequences of their preferences in light of what's immediately around them. Where there's network effects associated with network build-up and dissolution. We build our networks, and then our networks build us, much as Winston Churchill said about buildings. There's effects associated with dynamics that play out over time as a result of these interactions, and often a very important one is associated with delays, long time lags between a given trigger and an effect. There's adaptation and learning that go on, and there's nonlinearities, which have diverse implications, but one of them is if we, for example, double the size of an intervention, we don't necessarily double the gains from that intervention. We have effects that are not strictly linear, and those have profound implications for the behavior of the system, particularly in terms of emergent behavior. Okay, so these dynamic models, which we got a glimpse of today with a hybrid model, a model that combined agent-based elements with system dynamics elements, what role do they play? Well, fundamentally they try to capture posited causal relationships between different factors within a system. I say posited there because, as I say, they don't tell us what's going on in the world for sure, but rather they help us say, what if this is how it were? What would the implications be? Is that consistent, therefore, by extension, with the evidence that I have? So they allow us to sort of reason about more quickly, robustly, and rigorously about the impacts of our theories. And as such, they allow us to identify system vulnerabilities and leverage points, ways of fruitfully changing the system structure, and ways of working together more effectively. These models go by many names, and one of the difficulties in giving boot camps like this and in communicating in this area is that they have many different names by which they're called. You'll hear the term mathematical model, causal model. You'll hear them term models of the physics of a system, models of the plumbing of a system, mechanistic models, simulation models, dynamic models. And of course, you'll hear them by the number of particular proper names for different flavors by which they go by. System dynamics model, an agent-based model, a discrete event model. But they share some fundamental commonalities. Unfortunately, we live in a world that is highly tribal, and this area is no exception. And I have the scars to prove it. I'm a modeler who for 25 years has made use of these sorts of models, and for 23 or so of multiple types of modeling. And I have no room in my world for tribalism in this area. I think it's a crying shame. But you will find that there are many people who believe that they have a role to play in emphasizing one tradition as superior to the others. Frankly, I think it's nonsense. They each have a role to play that's very important, and most importantly, they can work together to give insights where the whole is greater than the sum of the parts. But the other fact that's often obscured in all the hullabaloo about them, is that they share more in common than most people realize, and they actually, I think, have more in common than they do in terms of differences from each other. They all depict kind of the physics of the system in different ways and with different frames. And they hypothesize typically a system that's associated with some state, which in most models from a statistical perspective would be termed latent. It's often not directly observable, or incompletely or imperfectly observable at the least. And all of them simulate the step-by-step evolution of the state of the system over time. So remember earlier we ran that model, we pressed that green button, or we right-clicked on the experiment and we say run, and it played out over time. Do you remember that? You saw people getting connected with each other, babies being born, people developing obesity, people's color changing, reflecting a change in health status. Here, it was simulating the evolution of the state of the system over time. Simulated population and its change in state as the model played out. How many people were obese? Which people were obese? How many people had gestational diabetes, etc. Now, critically, and this is absolutely central to the enterprise of model, because these models capture posited causal relationships, one of their foremost uses is to ask about counterfactual situations. We can now ask about, well, if B were to be changed in this way, how would it affect A and C? They can provide us a way of reasoning consistently about things where we lack direct evidence. We don't have statistical data for that situation, and we can instead ask about it in this sort of micro world. Is it guaranteed to be correct? No. It's not guaranteed to be correct. But it will be the logical consequences of how we are positing the system to work. And often that's what we want to know. If it worked this way, what would the implications be? If it worked this other way, what would the implications be? Do they both point us in the same way as to which intervention is most desirable, which intervention is likely to be most cost effective, or what have you? So within this context, within dynamic models, we're trying to specify some initial state of the model, rules indicating how the state changes based on the current state. So given the situation you're in, how is it going to change? What are the rates by which someone might develop diabetes if they're currently obese, for example, and of a certain age and a certain background? Or for a system dynamics model, how quickly the stocks will be changing. In other words, the rates of flows based on the current situation in a model. And there's similar constructs within discrete event modeling. And from such a specification of this initial state and these rules, the system can then map on a step-by-step basis how the system evolves over time. So, characteristic of these models across all traditions, we'll be seeing this week. They have evolving state. The models specify these incremental changes based on the current state. The system behavior is emergent. Those graphs that we saw up at the top of the screen, those weren't pre-programmed into the model. We didn't say make the level of gestational diabetes rise over time, make the level of obesity rise over time, have the number of diabetes cases rise twice as fast as the level of gestational diabetes. Those things were logical implications of the model, but they were implicit. We needed to run the model to understand those implications. We didn't pre-specify them. They emerge from the interaction of many different features. Just like in the world, ladies and gentlemen, the patterns that we see, the traffic jams that bedeviled you on your way in this morning, those resulted from the interactions of a lot of different pieces. They were not pre-planned by the city. They were not pre-specified, but they resulted from a lot of the decisions, particular drivers and the low visibility at certain places of the road and those long lights at certain places. And they were emergent features from the entangling of many different pieces. And very importantly, this behavior can't be pre-specified. We don't have any way, and we don't believe that logically there is a way, other than running these so-called nonlinear models, that we can anticipate ahead of time what their behavior is. We can't write down a formula for how this model will behave. We know since the days of Poincaré that that's not a possible avenue. And because the underlying systems out there tend to be nonlinear, generally the models incorporate that as well. Now, outside the health area, this is routine stuff. Well, not all areas outside of health, but many areas outside of health. So, none of us would want to fly in a plane unless the pilot had undergone extensive training in adverse weather conditions. And I can assure you that new pilots are not brought up to fly through the middle of thunderstorms with a 737 under their control. Rather, they're given flight simulators to test in, and they undergo thousands of hours of training in flight simulators to develop the skill of how to read the situation, how to respond, etc. And in case after case, industries and professions take these sort of tools as a given, as required. In the health area, there's a widespread recognition now that there is a real need for these models to complement the existing health toolbox. This is not about throwing out existing tools. We need all the tools we can get, and those tools tend to work synergistically with these dynamic models. So these models help us learn more quickly and think through the implications of our assumptions so that we can better put whatever empirical evidence we have to use. We can more quickly spot inconsistencies in our thinking, and we can better inform our choices and advance our understanding. Okay, so there's this co-evolution going on, ideally which involves intervention and actions and cross-checking a model and using it to refine our mental model, and using it to refine our physical model, running that physical model, seeing the degree to which it reflects empirical observations, refining further both our mental and formal modeling artifacts, and then combining it with observation and intervention. This is the broader enterprise in which these models are embedded. And in a delightful quote, which Depp has just unbelievably deep reading background. I'm just completely flummoxed by his level of familiarity with the literature. But he quoted for me Francis Bacon. The quote was, and I'm rendering it in English because my Latin is poor, it is easier to evolve truth from error than from confusion. And basically it means it's better to be transiently wrong than perpetually confused. It's better to put something out there, observe an inconsistency and improve it, than to sit back and say, well, we don't know what's going on. Models serve that role. Could they be wrong? Yes, they could be wrong. But we will spot that wrongness sooner than if simply what was in our head was wrong. We can't total things up in our head and compare the logical consequences to the world like we can with a model. Models can be wrong, and they will help us quicker recognize if we are wrong, if they're in a healthy relationship with collecting data and cross-checking the model. So with a model, we have a systematic way of replacing confusion by learning. It's kind of what it comes down to. Taking what was in our head in a sort of inchoate way, putting it into a way that's explicit, that can be shared, that can be critiqued, and that can be simulated so we can see its consequences and compare it with the evidence. So, by supporting theorizing concerning what's going on out there, these models aid in theory building, testing of theory, and in refinement. Let me emphasize those things again. Theory building, helping to formulate theory, it's an important use of models. Those models tend to be different models that are used in, for example, understanding, explicating the implications of a theory for which interventions are best. It's often at different stages of our thinking. But they can also be used in testing theory and refinement of theory. The observation here is even putting forward a poor model often advances our knowledge by allowing us to spot these inconsistencies between our assumptions and the evidence. So my colleague Don Burke, who's head of the School of Public Health at Pitt, University of Pittsburgh, and Josh Epstein, who's at Johns Hopkins, have both created lists of dozens of uses of models, of dynamic models. I've listed some of them here. I've emphasized one of the most important ones up there, but often what draws people to them, what draws practitioners to them, is this ability for them to serve to help manage a complex system. Serve as what-if tools to identify policies that are cost-effective, high leverage, that are robust given the uncertainties, evaluate benefits of somehow restructuring a system more broadly, to explain trends, to prioritize research, or to prioritize collection of data. We've been in a situation in my research group for putting down, a dozen $1,000 because of results of a model. We knew what variables exactly were most key, and we were willing to therefore put down a lot of money to help secure the data associated with those variables, because we knew it would be key in driving our model forward to the next level. And to understand classes of contexts in which certain strategies might work. And finally, they could serve as very potent communication tools. Far from being a technocratic artifact that's kept in the back office, built by someone with a very strong technical background, but which never really engages with stakeholders. These models can be incredibly powerful tools for engaging with those many stakeholders across many areas of a system. Even if they don't understand all aspects of a model, they'll understand pieces of it. Now, for the skeptics out there, of which I count myself one, of models, I would like to note this analogy between models and maps. The observation here, ladies and gentlemen, is that models, George Box once said, and I'm sure many of you will have heard the quote, all models are wrong, some models are useful. He said that about statistical models predominantly, but so it is with dynamic models and models in general. And the analogy I'd like to use here is to maps. Models, like maps, represent abstractions of features of the world. They hide a lot of detail. If we want to be able to drive through Melbourne, we use one sort of map for that purpose. The map would hide a tremendous amount of unnecessary detail. It would hide vagaries of exactly how many lanes are in each road. It would hide details of the availability of sidewalks. It would show almost nothing about exactly where the trolley tracks are, etc. And that would be useful for that purpose. By contrast, if we wanted to take the public transit system across Melbourne, we'd use a very different map. All of them, each of those maps would hide a tremendous amount of detail. Which bits of detail they hide will be different for each of these. All models and all maps are, in that sense, wrong, but they can be extremely useful. They can be extremely useful. They are fit for purpose. They're fit for a specific purpose. Now, the analogy is a wee bit glib because with models it's often difficult to ascertain a priori which information should be omitted. I talked about the entangled nature of systems out there. We have this entangling of, think about the burden of obesity. We have this entangling of issues concerning these different levels from physiologic to national level policy, all entangled together, and it's hard to know which things should best be omitted from my model. But we proceed in a step-by-step fashion in a way that allows us to explore and learn over time as to what needs to be in there, what's not. All these models will share the same concern of model scope. Which things are captured within the model? And I want to distinguish three types of things here in terms of how they're reflected in the scope of a model, the boundary of a model. There are things which are endogenous. These are things calculated by the model. The model computes them for us. The model generates them. We'll use different words for it. But basically the model, we don't tell the model what to assume about that, it tells us. It tells us how this will evolve over time. So that earlier model, we had a number of cases of gestational diabetes. That was an endogenous quantity. We had number of cases of frank type 2 diabetes in low-income populations. So it's an endogenous quantity. By contrast, there are some quantities which we tell the model what to assume. We give it a fixed number, or we say it has to be drawn from this distribution, or we will specify some pre-specified value, how it changes over time. The point is it's pre-specified. It's fixed in advance of running it. And we call those exogenous. They're represented in the model. They may influence things in the model, but they are not produced by the model. And finally, there are things that are ignored. The model simply leaves out. Okay? And there's a trade-off here, because capturing factors endogenously adds flexibility and investigative power and accuracy, but it can also require much more time, and it's more challenging to reason about. Okay, I'm going to stop my comments here about sort of background comments on system science, what we're engaged in this broader enterprise. Are there any questions about that before I go into the next little bit, where I'll be talking